Okay, so another surgery day, another oral and maxillofacial surgery. This time another total unilateral maxillectomy for a dog with a incompletely excised squamous cell carcinoma of the caudal left maxilla from another practice. We did a CT yesterday. There's basically palatine bone involvement extending back to the orbit. But because it's a brachycephalic dog, we need to take, to get margins, we basically need to take the entire unilateral maxilla. On CT scan, no evidence of metastatic disease. All three of the left mandibular, left medial retropharyngeal and left parotid nodes lit up on the sentinel lymph node mapping. I'm just going to take the mandibular lymph node and then progress on to doing the maxillectomy. So in this case, I'm not doing interoperative methylene blue, just because I know where the mandibular node is. You can palpate it just here, and the methylene blue kind of messes up visually the surgical field. Thanks. So the nice thing with doing oral and maxillofacial surgery in brachycephalic breeds is that they usually have a fairly broad face with long lips, so they don't usually have too much of a cosmetic defect afterwards. And because they're used to eating with not much jaw length and not many teeth, they tend to bounce back from this kind of thing really quickly. So a node in there. I think that's our node, but not 100% certain.
You okay to scrub it?
Yeah.
You can scrub it. You can scrub it.
Can you hit the button for another photo, please? At the top there, you can get a bit closer. Closer. Okay, that's good. Right, thanks. So I don't know whether you can appreciate here, might be a bit difficult on how close we are, but this is the lateral node and this is the medial node of the mandibular centrum there. Can we get some 3.0 monocle, please?
Can we get a histojar too? Oh, I guess are you?
What's that?
You're putting the histojar, right?
Yeah. Yeah. So the rotation flap on that cat's still looking good.
Oh, good. Oh, those are very sweet.
Yeah. I hadn't seen them for like 3 months, like the consult was back in June. So I kind of forgot what they were like. And they were very, yeah, very sweet.
Any necrosis at the distal tip, or?
Nope.
It all looks really good.
It's all look,
Great.
based on the photos at least. I think she's medical, so I think
She is,
she's
yeah. Nurse.
she's got a good idea of description as well.
Actually, I believe she works in like the head and neck surgery department.
Oh, really?
Yeah, so she was like aware of types of flaps and complications. How was the thoracotomy?
Really cool. Yeah.
Why did it need a auto transfusion? Like, did they hit something? No, the thoracotomy.
No, there was a quote of pericardium. So she for the COVID didn't need a transfusion.
Oh, I thought it did.
They just got everything ready.
Okay, so can you call them in? We'll just kind of change. I'm just going to move this a little bit. Okay, just raise it a bit.
The tube, because of how the mouth gag and that is, I don't really have anywhere to tie, so we stapled the tie underneath his chin for
Okay.
the tube.
Can you focus, come down closer to this area? Okay, that's good there. Thanks. So again, we're going to do this combined approach to this maxillectomy. We're going to take some of this zygomatic arch out. So we're going to come along the nose here. Being a brachycephalic's a little bit of a challenge, obviously, but the canine's there. Come a bit more up here. Past this facial fold. Up onto the zygomatic arch there. You can just kind of put tension on that side. Yeah, thanks. Come through the scalpel a bit more. So I'm going to cut wide. There's just a incision into the periosteum, reflecting that off to get down to the dorsal and ventral aspects of the zygomatic arch. And then we're going to reflect off the temporal and masseter muscle insertions on that. This is going to dip down ventrally along here. Yep. We need to expand that a little bit later. It's going through that supraorbital ligament here. The zygomatic arch is pretty thick, so it's coming along the medial aspect now, taking that masseter muscle off, coming in here along the ventral aspect as it heads down to the maxilla. And then dorsally, same kind of thing. I'm just going to make my way around here. So that all feels good there. So we've kind of got our first cut on the zygomatic arch there isolated. Now we're just going to continue further deeply. Can I grab another photo, please? Just hold that back like so. Sorry, there you go. It's another photo, please. If you do it the other way around, lengthways, sorry, yeah.
What's that one?
No, that's good. You may need to go higher. Yeah, great, thanks. Okay, thanks. Okay, I'm just going to get in here. I'm just going to get through the soft tissues now here. A bit incised through that conjunctival tissue anyway, but so we get down and make this bipedical flap. So if you just hold that up like so. So this is the tumour here, but there's suture material here, so we're going to need to make our way around that. And we're going to do a cut kind of through there. Okay, so I want to take probably about 5mm margins around the soft tissue component of this mass here. Can I grab another photo, please? And come back caudally about the same amount. Grab another photo, please. And then another one as I kind of come through. There. Okay. And then okay, there as well. I'm not sure you're going to see that, but okay. So I've made cuts in the buccal mucosa and the palatine or the mucoperiosteum. I'm just undermining the mucoperiosteum now with the periosteo elevator, because again I'm more concerned with my bone margins and my soft tissue margins. So I'm going to reflect more of this mucoperiosteum towards the midline. You do get some bleeding from the major palatine artery, but usually that stops while you're working on other aspects. So I'm not overly concerned about that bleeding. So the first part of this surgery is always setting up for your osteotomies. So it's kind of a very organised surgery in a way in that respect. And now I'm just joining up the caudal incision with the mucoperiosteum, periosteal incision, and the buccal incision. Okay. Right through there. Okay, so now we're just going to work our way to create this bipedical flap. Okay, so we're pretty close to connecting the flap. Oh, sorry. Let's see if we can. Oh, sorry, just touch your head. If you stop, rotate it, come back around. Yeah, if you can get around that without moving this too much. Yeah. If you can point, you can grab it now, and then point it more into the mouth. Can I have some more gloves? Sorry. Tina?
Sorry?
Can I have another glove, please? Just another glove, please. Thanks. Thanks. Okay, so you might be able to get a better look in the mouth with the light position that way now. Soft tissue in the back of the orbit there, or front of the orbit, I should say. So it's just the masseter muscle within the orbit there. So are we all released? So now we kind of, I think we've released nearly all of the this bipedical flap here. So we can move it down to expose our lateral and dorsal lateral maxilla for some of the osteotomies, and pull it the other way around to better expose our oral cavity. Can I grab more photos, please? And you can see here now that the palatine cut, or the mucoperiosteal cut, is bleeding minimally. So just a photo in there. No flash on. And another photo like so. If you move it down a little bit, so you get the bottom of this flap in. Yeah. Oops. Great, thanks. Okay, so now we're just going to incise along the rostral orbit to get that cut planned, and then we're more or less ready to start our bone cuts. A supraorbital ligament here. Hey.
How's it going?
We're almost about to start our osteotomies.
What do you think from here?
I would say a good hour.
An hour from here?
Yeah.
Okay.
So my aim is to save the eye. The only reason to take the eye is to really get the margins or to get a better access for margins, but I think we can do that without compromising the eye. So I think we've got pretty good access now. So we're now going to start cuts. So we're just going to start with the zygomatic arch here. It's going to protect the tissues underneath. This is periosteal elevator. If I can get it through, just hold that there, Diane. Can I grab another photo, please?
That's the tree section.
Another photo, please. Just of that. Thank you. Am I on you? Yeah. Yeah. Okay, so we're through that one. Now our next one is usually the rostral one, which is going to be through here. And then we'll come up along just hold that up there for me. Then we're going to come up along the dorsolateral. You okay, Tina? That's okay, don't worry. There, not quite where we want to be, but getting close. Okay, if I can have another photo, please. Just another photo of that. Thank you. Okay, so we're just going to come around the other way and bring this down. Let's see if I've got enough space there. So I'm just going to bring this flap over the canine tooth there. I'm just going to continue up along into this area here. I may need to just clear more of that away. This is the challenge with brachycephalic skulls. Okay. So I'll just get you in there gently just to make sure I don't ding the eye. If you can just suction along here for me, please, Hedian. That's good. Doesn't feel like it's cutting great. Okay, suction again. Okay. Suction. Okay. Can I have another photo, please? So, a couple of photos. One along that way. And then another. I'll swap with you there. Just hold that up for me. And along, say there. Great, thanks. Okay, can you put the table up for us? Great, thanks. If you hold that there. Let's see if we can get a better view in there with the camera. Okay. So this is a mucosal cut here, coming along the zygomatic arch up to here. This is the caudal maxilla, and this is our mucoperiosteal incision. I've reflected that back a good ways so I can get margins around the tumour, which you can kind of see just here. So I'm trying not to get my head in the way while I do this, but I'll start with connecting up the rostral cut first. So that feels good. And I'm going to start working my way towards the midline. That's good. That's through there. Through there, which is good. And it all feels good. Feels good. I think we're pretty much there on that aspect of things. I'm just going to see if I can delineate it further with the osteotome. I'm happy with those bone margins. Feels good. Just going to make sure we're through here. So that all feels good. Okay, I think that's good. Okay, so I think we're all pretty good there. This I'm pretty happy with. Yep, so the last cut is the one where we may hit the maxillary artery, so that's always the last cut. So let's swap with you there, Matteo. So I want to come back far enough here where I'm into the medial orbit. And then directing, this is where the tumour ends up. So I just want to come down into here. I'm just going to come around here, kind of halfway through the orbit, connect up this cut here. Can I get another photo, please? Yeah. That's good. Another one, maybe just of everything. Sorry, side on.
Side still?
Yeah, that way. Yep. Thanks. So I'm just coming along the kind of the mid aspect of the orbit. The orbital bone is usually fairly thin. It's seeming to be a little bit recalcitrant right now. Okay, that's better. And now we're kind of through the orbital bone. I just want to connect up caudally here so we get good margins both caudally and dorsally within the orbit. Hey.
How available are you to give an opinion next door?
Give me about 5 minutes because I'm just at maxillary artery.
Okay.
Okay. So we've come along here medially. We're pretty good, I think. So now I'm just going to angle down from there to get a caudal cut on the orbit. Okay, this is where we get some bleeding. Okay, so just put a thing in there now. Let's just see if we can prize this out again. You just hold that out there. He's out the back here. There he is. And then just in here. So just that there. Yes. Move that towards you. Okay, so this is a squamous cell carcinoma here. We've got a good 5mm margin on the soft tissue, more on the palatine cut, which is here, and this is a zygomatic cut. So that's a total unilateral maxillectomy, and this is what we're left with now. So we're just going to, there's a little bit more soft tissue margins there. That we're going to remove, but the maxillary artery is being controlled while we've been resecting that out, but we'll have another look for that. So yeah, that's the completed total unilateral maxillectomy. I'll just get you to come around here for a sec. Yeah. Let's remove, there's a bit more margins there on the soft tissue. Yeah.
Okay, underneath, the dog that came in through ER for the incision.
Yeah.
The owner is still waiting. ER has asked us to manage it because they haven't gotten to it. And
Okay.
we have the photo that ER took. It does look a bit gooey.
Yeah.
But I didn't know if you just wanted to.
You bring her out the back. Bring her into induction, and I'll have a quick look. I think what we've got going on here is that we've gone past midline, so that midline septum is holding on. So we're just going to remove that. There we go. So the nasal septal bone was holding on to our, because we'd gone past midline with our bone cut, and so that nasal septal was holding on there. So we'll submit that as separate margins. So this is, for any of you who were watching last week when we did a similar surgery where we had more blood loss, this is more what I typically see. So we had we quickly were able to get that maxillary artery under control, and so this is typical for me. So I'm just going to take a few minutes just to look at this other dog and help out the other surgeon. So maybe you can just give that a flush. And just so you know, Tina, other than what's there, we've probably got 20 mils of blood.
Okay, I do have a decrease in blood pressure. I'm going to see what my next one is. If it is still low, do you want me to do like a 3 ml per kilo of bullets?
Sure. We only had like
Just a minimal.
30 seconds of arterial bleeding. So, can you open that for me? Thanks. Yo. Hey.
Have you seen this before? Pat's presenting for an X-lab and biopsies for elevated bilirubin, checking to see if it needed a Foley. Found these interesting yellow boba-like structures along both the common bile duct and then underneath by the portal vein.
So they're just lymphatics.
You think that's just lymphatics that are
Yeah.
yellow and they're distended for unknown cause, unknown reasons?
Is the yeah, I don't know why they're distended, but they're
Sure.
just lymphatics.
Okay.
Is the cat jaundiced or anything?
Yes.
That would be why.
Okay, so in terms of the like kind of ball-like appearance, not surprising to you, like
No.
in that sense? Okay,
No, that's
cool.
fine.
That's great.
Yeah.
Thank
Yeah.
you. Thanks for
You need your table up.
what do you say?
You need your table up.
Yeah, we were
I think that they put that there for drugs being drawn. I don't know. Oh, there we go. All right. So they said they noticed that
Which leg is it?
the was kind
I'll do another photo actually. Jess, sorry, can I get another couple of photos? So just a photo in there of the defect. And maybe another one on the other side. I'll just stop with you there. That's straight over the top. If you can do it the other way, landscape, so it's that way. Okay, and then last one, I'm going to grab a faucet and just hold that there. And just something like that. Yep, thanks.
Do you want your suture now as well?
Sure. Can I have some 3.0 PDS on a cutting needle? Maybe 2 packets of that. And then 3.0 3.0 monochrome, please. Yeah. Let's make it a cutting. So I'm just splitting the lip right now. And brachycephalics typically have a fairly deep lips or long lips, so that makes these reconstructions quite nice. I want to go out to that lip margin to reduce the tension on the closure. Okay, let's move it this way. In there. In there.
Sorry,
In there. And more kind of up. Whoops, it's not working. No. It's a bit of edema, just need to. There we go. Now we got our plane. So the cosmetic success of this procedure really depends on what we do here. So you really need to bring it up to that lip margin, free it all the way up of soft tissue attachments. Particularly when we've got such a medial dissection on the on the hard palate, because that's really going to drag this lip in. So you want to free this up as much as possible. Just come down here a bit. You come into here. Ask me a question.
Sorry. I'm not trying to talk about you right here. I'm just wondering how far along you are and when I should start the next one of your revision.
I am closing now, so you could probably.
We're just I am sedating and then just kind of
Okay.
waiting.
Maybe give me 10 minutes
Okay.
before you start.
By the time I'm out there, you'll be ready to go then?
Roughly, yeah.
Tight ship.
What's that?
It's a tight ship.
As in
As
case
in
to case?
You have up to a 10-minute. You have your timing down to
No,
10 minutes.
no, they can wait a little bit too if need be. In total, we have, 9 surgeries today, so need to keep things moving. Not too concerned about the rostral aspect, because obviously that defect's not huge. Let's work our way around here again, make sure we're good here. So you come up here, Mateo. No, you come down here. Mateo, if you come to there. That's okay, you can stop.
Okay.
Yeah. Okay. Okay, so I think we're pretty good there. So yeah, that'll come down quite nicely. So we'll get some, maybe a bit of sucking in there, but not much. Okay. So again, we're just going to start here. I'm going to do one of our combined closures again, just because it's so difficult getting up here quarterly. Do you close the last one with simple continuous or cruciates in the palate?
I did simple continuous. Is that okay? You typically.
Well, I think I closed the palate.
Oh, sorry. My mind's
Yeah.
thinking when you said last one, I thought you meant the last surgery.
I
think
forget.
you did. Oh,
Short there. That's good.
I think you did cruciates.
I think I did too. Yeah. I'll bring this in just so we get a better view. Just trying to give you guys a better view as we close. So again, just the submucosa of the labial flap and the mucoperiosteum. Our most common complication here is dehiscence, which happens about 30% of dogs. So trying to reduce that risk by doing a two-layer closure in the mucoperiosteum and labial mucosal submucosal flap. I'm just going to stop that one there and start to do the mucosal layer. And that was a load of good. Can I have another 3.0? The needle just came off that one. No, the 3.0 PDS on a cutting needle. Cutting? That's not cutting. Yeah, it's better. Yeah, thanks.
Sorry.
Okay.
Double check.
Why not do this on a tilt procedure?
That's a good question. Never thought about it before. At this point, that kind of makes sense, but obviously we're working both sides of the head, so less easy.
Both?
Yeah. Yeah, but okay, you can maybe release that, Matteo. Let's see how that goes. Or maybe just hold it more gently there, yeah. This is kind of the hard part here where Matteo is trying to give me as much exposure as possible, which is great, but then that puts a little bit more tension on the closure, and so it's a balancing act. So I'm just going to add the mucosa once again. You can hold that one. Yeah, thanks. The problem with the PDS on the cutting needles, it's undyed, so it's hard to see in the back of a mouth that's pigmented and a little bit bloody. And I'm old, my eyes are going, my glasses are sprayed with blood, and I can't quite see through them well. So now we're getting out the caudal aspect of the oral cavity, so it just gets a little bit easier. Straighten it up a little bit. That's better. That's fine. Yeah.
Julius, can I answer your question about Marty?
Mm-hmm.
Austin is wondering about starting him on a dexamethasone. He's already off of his ketamine because he keeps turning. And
Okay.
they take him outside and he still won't settle.
Okay.
Are you okay with
Yeah.
that?
Yeah.
Just watch your head on there, Ken.
Thank you. Let me just hold it out and try like that.
You know when they say skin of your teeth?
Hmm.
You got away by the skin of your teeth.
What's that?
When they say like you got away by the skin of your teeth,
Mm-hmm.
you're trying to suture the skin of the teeth.
Almost.
What was that joke again you told us the other day? Was it a chicken coop one? Yeah. Do you want to hear it again?
Yeah, I do.
Oh,
I wanted to bring it up to someone.
oh it's
Telling bad jokes.
yeah. It's, why does every chicken coop have two doors?
Okay, that's what it was.
If it had four, it'd be a chicken sedan. Nice, clean, clear. Animal related.
Okay, so let's finish up the mucosal closure now. I get to mailbox. No, all that back there. First surgical intern way back when. Had a friend that was doing her third year residency in a big academic school, and he had done more maxillectomies and mandibulectomies in the first 2 months than she had done in 3 years. So maybe you'll get a similar experience here.
I have a case of stress.
That's fine. Yep. Yeah, so
Good to continue?
Yeah.
What drew you to surgical oncology?
Oh, it's almost like a calling. So in Australia, the system's a little bit different. You don't start a residency until you've set your membership, so that's what the way it used to be. And you could only sit your memberships 4 years out. And so I was doing general practice. I was not happy with it. So I was looking to other stuff to do. Pretty convinced I wanted to do surgery. So I really concentrated on that. Then my boss at the time did this medical oncology course, like distance education medical oncology course, and that seemed pretty interesting. But the thing that really switched me was I went to a surgical oncology conference. So Rod Straw was the first fellow first ever surgical oncology fellow, and he was giving this, he's Australian, he was giving this course in Thredbo in Australia, and it was just like it clicked. This is what I want to do. I like the combination of surgery and statistics and research, and then as it kind of developed, it was a really good group of people. There's kind of no real egos involved. We're all kind of there to cure cancer, as they say. Or at least do the very best we can by our patients.
Well, I've been desperately trying to think of any surgical oncology jokes. I'm trying to make some up. The best I've come up with so far is it's black and white and red all over. Combination with mast cell tumors. That's good. I'm sure there's more. I'm really struggling.
Maybe Sarah has some.
That feels like cheating. That's being a pro.
See it there, I can't grab it. Okay.
It's hard to see. Like what? One of my rotations near the end of the year is going to be with surgery at Pulse.
Mm-hmm.
One of the surgeons there, Chuck,
Yep.
was known in this clinic. And,
Yeah.
Phil in New Zealand told me an anecdote between you, Chuck, and him. I'm
Uh-huh.
trying to remember the details, but I know it existed. I'll have to ask him when I get there.
Chuck and I worked together. I was there 16 years. He must have been there at least 12 to 14 years. So, and he's his best friend. So, there's a Andy, him and Graham go skiing somewhere exotic every year. Thanks. This is monochrome, isn't it? That's the PDS. Thanks.
What's that? Long?
No, short. Or shorter.
Oh, for the section. Oh, I remember another one. Bear walks into a bar. He goes to the bartender and he says, "I'll have a Coke and whiskey." the long pause. I guess I was born with them.
Okay, so that's the a two-layer closure on the palatine aspect of things. Now we're just going to close this wound, the dorsolateral skin wound. Matteo is going to do that for us while I look at this other dog. So maybe just use a 3A PDS for the kind of the muscle layer and the intradermal.
Okay.
We've got some photos. I've touched this, so I'm just going to do it this way. And as you can, kind of Matteo hasn't finished the closure yet, but you can appreciate that, oops, let's get this right. It feels like playing a video game and I'm all back to front. So you can appreciate here that the facial features are still very similar to the way we started, despite removing so much bone and tissue. So this is how a lot of brachycephalics are. So this is a nice surgery to do in that respect. Not just much in. What's that?
Can we get you through PS or just?
That's okay. And then this is the 3A monochrome there for the intradermal. I'm just going to ink that.
Building checklist?
Yep.
No cost, full self-analgesic plan, meloxicam.
Yep.
Ketamine, fentanyl, CRIs, and buprenorphine before we go home.
Yep.
Going to recovery? Or will I
Yep.
see you
Recovery's fine.
when it goes to any requirements prior to recovery? Any x-rays?
No.
Perfect. Post-op fluid rate at 50.
Yep.
mL per kilo per day. And we have 2 samples, the lymph node and urine.
There's actually a third one here too.
Third, okay.
Just margins.
Oh, margin, okay.
Yep.
Okay, and literature reviews and closure type, we'll just agree to do,
Intradermal
perfect.
for both. And Matteo will take care of the shafts afterwards.
Alright, excellent, thank you.
Thank you all. That's okay. Okay, let's grab a photo inside the mouth there. I just reflect the lip so I can. Great. And then when you're finished, if you can take one from the top. Thanks.